Welcome to Kartzinel Conversations. And I'm Dr. Jerry Kartzinel, and we're going to have a conversation, all right? We're going to be discussing topics to autism and their medical issues that our guys and gals present with that are largely ignored by our medical community. You know, we could start with a patient that I had and then kind of build about how I go about doing things and then how we treat them. So first, it wasn't long ago where I had a 18-month-old come to my office that presented with extreme irritability. It was an 18-month-old. Rage, pinching, biting, kicking. Grandma and grandpa were just exhausted. Mom was exhausted. They were bruised. They were pinched. It was just terrible. What's worse, the child was put on Prozac. I couldn't believe it. Who puts an 18-month-old on Prozac? It was the youngest I've ever seen. It just didn't make sense. And of course, it wasn't working because the underlying problem was not figured out, elucidated. It just wasn't even addressed. Oh, well, we have autism, so therefore we must be aggressive. Well, I took an x-ray of his tummy and he was really severely impacted with stool. I mean, his belly was swollen, it was huge, it looked like he was pregnant. So that is kind of a constellation of symptoms that we have here. So welcome to Kartzinel Conversations. Let's get going. I'm kind of excited to share this with you today. You know, if you came to my office and you wanted me to figure out what's going on with your child, I'd be asking, obviously, a lot of questions. Questions that you don't get asked at your pediatricians or the behavioral pediatricians or the neurologists. They see things very limited and they come in with a bias. We call it conformational bias. Well, here's another kid with autism. Have to tell mom this is kind of a normal pathway that many kids are going down these days. And yes, they can be aggressive and irritable and cranky and not sleep and not want to eat. And the list goes on, right? I mean, you have kids with lots of problems. But really, it's not a miracle moment when you come into my office. It's not like, oh, I know what's going on. It's questions like, what's going on here? Pattern recognition. And very often I'll start with, well, how was the pregnancy? Were there any complications during the pregnancy? Did you get vaccinated during the pregnancy? How was the delivery? What did we do for the first 6 months of life? Were we developing normally? Were we breastfeeding, bottle feeding, smiling, cooing, making eye contact, turning to our name at 8 months, 9 months? How did that first year? A year and a half. What were we doing? Did you see a regression? Did we lose symptoms? Did we lose something that we were doing? Oh, we were colicky the first 6 months of life. Oh, we spit up milk all the time. Or I need to know these things. Oh, he had normal bowel movements until we started cow milk formula. Or we were having constipation from the get-go, from the newborn nursery. We were having diarrhea all the time, and the doctor told us that was normal. Really? Toddler's diarrhea, they'd say. Oh, if my German Shepherd had diarrhea, the vet would not say that that was normal. So it needs to be evaluated as there's something medical here. Why? Because our kids tell us that something is wrong by their behaviors. The behaviors aren't just autism, the behaviors are them saying, I don't feel good about something. And it could be bad constipation, it could be diarrhea, it could be abdominal pain, it could be headaches, it could be inflammation, recurrent illnesses, but they're telling us, I don't feel good. And the only way they can tell us that is by acting out, not sleeping, being just very difficult. And you know what I mean. So we look at a constellation of symptoms. What is everything going on in your life? Well, he's not sleeping. He's very picky eating. He only has a bowel movement every 3 days. He's got diarrhea all the time. He keeps getting ear infections, and he keeps going on antibiotics for the ear infections. That was kind of my son. He started off okay, and then started getting ear infections, and I treat the with antibiotics and get more ear infections. At one point, the doctor I was working with thought, you better do a spinal tap. We were worried about meningitis. This kid was sick all the time. So the more I tried to do for him, the sicker he got. So it wasn't a great thing. So these behaviors, these physical symptoms and signs can help me figure out where I want to go with my evaluation. When did this first happen? Is it what makes it better? What makes it worse? So I start with just the family history. Has there been schizophrenia, bipolar, alcoholism, suicide, substance abuse, not seeing well, driving at night blindness? And then we get into what things are really currently bothering mom. We're stimming a lot, we're playing with our spit. There are things that are going on that need to be addressed, and I have to prioritize them, okay? Because you're going to come with a lot of things. But if it's sleep issues, first and foremost, I'm going to take care of that. If it's bowel issues, another first and foremost, I'm going to take care of that because they kind of go together, all right? So we're going to be looking for different clues, clinical clues that I can use to figure out where I want to go with this particular child. And every child is different. And you know that if you have a child on the spectrum and you see other kids at the school or something, yeah, they have the diagnosis of autism, but they're really different from each other. So we have to individualize the approach to helping them feel better. Are we having problems with sensory issues? We don't like our hair washed or nail cut. Haircuts is a common one. Vacuum cleaners. Afraid of ants, flies, butterflies, irrational fears, right? Going places, is it terrible making transitions from the house to the car to school, back? Are the transitions an issue going from, as our ABA therapist would say, a preferred activity to a less preferred activity? And they try to do the behavioral thing. But I wish it was them because I can tell them what to do. It's really a me thing. I have to figure out what's imbalanced in these children. Sleep is a big one, all right? And we'll be talking about sleep all by itself, maybe a couple of sessions on sleep. We're not going to talk about that today. We're going to focus today more or less on the constipation, but we're not quite there yet. Again, when you have a child who's not feeling well, they are going to manifest behaviors. And we can't just blow the behaviors off as just being autistic or oppositional defiant. It's usually something communicating to us that we're not doing well. Because in my clinical practice, behaviors don't operate in a vacuum. There's usually something that's causing it. It might be hard to pinpoint it, like anxiety, but there's definitely something. When you get a tummy ache, you can tell me your tummy hurts. A neurotypical child has a tummy ache, mommy, my tummy hurts. Our kids can't tell us that, but they can show us that. How are our children who are constipated commonly showing us they have a problem in their belly? Well, they will roll over on something and like a ball or the edge of a couch. They will press on their belly. They can become aggressive. They can bite. They can grind their teeth. Okay. They'll scratch. They'll scream, or they'll withdraw. They'll stop eating. Now, even if they're having a bowel movement every day, their body might be producing that much poop, but they're only pooping out that much. So it accumulates over time. That's how they get backed up. Sometimes you can see it, and that gives you a very round, protuberant belly that I call the Prager belly look. Probably not a great medical term, right? But it creates a mental image that what we're dealing with is a belly that's distended. Now, can you imagine how you would feel if your belly was distended to the same degree as your child and it was all poop? You'd feel miserable. I promise you. It's just really very uncomfortable. So you don't treat that behavior, you treat the underlying cause of the behavior. So this is how we have to change our thinking in medicine. This is how we have to basically take what's in front of us and apply it and make changes, which is really kind of exciting. So there can be these physiologic responses, these behavior responses. Um, how do I get down to it? Well, when did this behavior start? Oh, it started when we changed from breast milk to cow milk. It started when we were introducing food. It started, we don't know why, it just started at 18 months. All of a sudden, the stools changed. Something like that. And is it cyclical, meaning sometimes he has normal stools, sometimes she has loose stools? What's going on with the stools? How do they smell? They smell foul, um, chemically, sweet, like a bakery. Yeah, I've had sweet smelling bakery stools. That's yeast. And that will be another topic we're going to be talking about. In our conversations, we are going to cover everything from stem to stern. But we have to look at these kids methodically and think about all the things that we're kind of concerned about and then prioritize them because we can't do everything at once. And sometimes if you come to me with 10 problems and I fix the bowel issues, invariably 5 or 6 of those problems go away. Not all of them, I wish. Okay, but a whole lot of them go away. And then we don't have to worry about them anymore. We can get down to what we're doing. So you have to form a bit of a hypothesis. This is constipation. You have to do an intervention. We'll be talking about that, how to relieve the constipation. And then we have to do some observation. Oh my goodness, he's so much better. She's sleeping through the night. We're not grinding our teeth. We're not throwing tantrums anymore. She's more flexible, more friendly. We're doing new things. These are things that we're observing. Our kids don't give a placebo effect. What you see is what you get. And that's kind of rewarding for me because it's like I get these emails back. It's like, oh, she's doing so much better. So anyway, we have to look at one thing at a time. I call it pulling one lever. It's the sleep lever or the stool lever or whatever. We can't do them all because we don't know what's going to get better because they kind of act on each other. So let's get back to our little guy that came to my clinic with his grandparents and mom, and they're all scratched up and bruised up and pinched and everything, and he's on Prozac, and I go ahead and I see that tummy is big, but he's a little guy, so I want to make sure that he doesn't have a tumor. They can have a solid tumor of the kidney, okay, and it's called a Wilms tumor. I mean, I'm just trying to think what can make a belly protuberant, and usually you can't do a great physical exam on these children because they don't like you touching them. They don't like being put on their back. They don't like being held still. And they certainly don't want me pressing on their belly and feeling for the liver edge and the kidneys and all that kind of stuff. So we get an x-ray. And if the x-ray comes back FOS, full of stool, then I know my job is to relieve that. If it doesn't come back and we have a protuberant belly, then I have to do some other evaluations to make sure there's not something else I need to consider going on in there. But anyway, the key is that the constipation doesn't always look like constipation. We talked about that. They make more poop than they eliminate every day. So the parents say, well, he's pooping every day. It can't be constipation. And I'm saying, well, maybe. Now, of course, the x-rays don't lie. A picture's worth 1,000 words, so I have that. Some parents don't realize they're constipated. Mom says, well, I only poop once a week. What's the problem here? Okay, well, we've got two problems here. We've got to treat mom and we've got to treat the child. I usually use the word picture. Look, have you ever had a dog? I have a German Shepherd. He poops every day. All God's creatures poop every day. So when your baby's not pooping every day, that's a problem. The colon is a muscular tube, and it moves stool with a term that we call peristalsis, which is kind of like when you were a kid in the shower and you had a bar of soap and you'd squish it and go up in one hand and kind of walk up. Well, that's how the stools get moved in the bowels. And if that muscular tube isn't working properly, mitochondrial disease you may be thinking of, then we have a problem. Or the stool is just too hard and we have to give them something soft. But when the stool accumulates in the colon, it stretches it out. It stretches it out. Now, the colon is not an elastic organ. It doesn't, like a rubber band, just go right back. Your lungs do that. Take a breath in and out they go. But the colon doesn't do that. It stays distended, and it can stay distended for oh, maybe 6 months, a year and a half. It takes a while for it to shrink back down to the size of the toilet paper tube. So that colon can be distended and it will want to accumulate stool. It's just a stool holder. Why is this a problem? Well, obviously you have the physical problem of a distended belly and distended colon, but the colon sends signals to the brain it is distended. Much like when our bladder is distended, when we have a lot of urine, it sends signals to the brain continuously until we relieve our bladder, right? Well, the colon does the same thing. It's just that the child's not acting on it. Remember, autism is an abnormal response to everyday stimuli. We talked about that last time. And the abnormal response is not feeling it. So I had a 28-year-old who just learned to spell to communicate. This is great. And very, very smart. What he knows is just amazing. You wouldn't have known it until he got him to spell to communicate. And his mom asked him, why are we still in diapers? And he said, Mom, there are times I just can't feel my bladder or my rectum. I'm just unaware of that. I don't feel it. So that's the first time now that I have, basic understanding of what's going on with some of these kids. See, we can talk about, oh, he's not pooping because it's willful withholding of stool. It's the only area of his body that he has control over, and blah, blah, blah. That comes from our ABA and psychiatry and all that kind of stuff. But really, what if it's not? And I would venture to say 99% of the time, it's not willful stool holding behavior. Maybe they don't feel it. Remember, abnormal responses to everyday stimuli. So they don't go to evacuate their bowels. They don't go and have a poop. But the colon is still sending signals. Now you know what it feels like when your colon is full and you got to go and you can't. It creates anxiety. It creates irritability. It's a different feeling than your bladder, right? You just don't feel right, and that's what's going on with our guys. And it's constant. It's constant and constant. So very often I'll get a history that, yeah, after he has a very good bowel movement, we had to give him an enema or whatever, and he's got a great bowel movement. He is so calm and so sweet and so wonderful for about a couple hours. And then, well, everything moves over as it should, locks and loads for the next evacuation. But they're not. They're not going to evacuate for a couple more days until you and I do something about that, right? So they are in pain. It changes behaviors. Now it can change sleep patterns, wake them up. They get a cramp at 2 in the morning, but they've been asleep since 8:39. Their batteries are charged. They got woke up and they're not going back to sleep. Surprise, it's a toddler party time between 2 and 6 a.m. Now, my wife has noticed that she loves her son very much, a whole lot less at 2 in the morning. You know what I mean about that. I say it in fun, okay? But it's very hard on parents, especially if you have parents who need to sleep. My wife needs to sleep. I can get up at 2 or 3 in the morning. I'm good with that. But my wife, no, that's not a good thing. She would say, I can just about deal with anything during the day, but don't interrupt my sleep 8 hours a night. So that was a job for me to figure out early on. So bowels can be inflamed. That causes behavioral changes. That stagnant stool, like that stool that's just sitting at 98.6 degrees in a dark, moist environment with very low oxygen levels, that's going to grow all kinds of stuff. Ew. I mean, it's like that's where you hear about my kid has a fungal infection, a yeast infection, a bacterial infection. He's got PANS and PANDAS. These organisms are growing. Well, they're growing in stagnant poop, brackish waters. And that's why it comes out smelling quite foul and yucky. So we have to look at that. Foul breath. Oh, I brush his teeth all the time and his breath is still terrible. Well, the colon absorbs water. It's what its job is to do. It's a water reclamation plant. You know what it's like when it doesn't work, we get diarrhea. So it's constantly absorbing the water. Well, the water's got all that, material in it that's just awful from the bacteria and the yeast processing, because they're living organisms. They poop and pee too, if you will. And that gets into our bloodstream, and then it off gases in our lungs. Breath in, breath out. much like when you've been by somebody who maybe had a binge night of drinking and you're in the elevator with them and they're just exuding that wonderful smell. Okay, so that's what that smell is from. So when they have bad breath, you brush their teeth, it's coming from the lungs, which are basically exchanging the gases from the colon. All right, so that is pretty much what we're seeing here. We're going to wrap it up here for today. Next time, we are going to talk about the actual treatments that I use in my clinic for constipation. And there's a bunch of them, right? And it has to be tailored for your child. But I want you to get a feeling that this is all approachable and we can actually fix a lot of the issues. And when we do that, their behaviors improve dramatically and it makes them more teachable, more reachable, more part of our world. Basically, it improves their quality of life. And my wife would say, if you can improve Josh's quality of life, you improve my quality of life. And if I improve my wife's quality of life, I benefit from that too. So again, I want to thank you for joining us in Kartzinel Conversations. I'm Dr. Jerry Kartzinel, and I'll look forward to speaking with you in another conversation next week.